Welcome everybody. We are still waiting for a few attendees to join, and hopefully we will be able to start our session soon. We will be starting now, and let me introduce myself. I am Dr. Hussain. I am the consultant psychiatrist. I am also the master trainer for mhGAP and international coordinator for mhGAP in Kashmir. Today's presentation will be about the work of mhGAP team in Kashmir. I'm going to break my presentation into two parts. The first part will include the presentation that I made to the President of the Royal College, Professor James U. Bailey, when I initially requested help from the college. And the second same presentation was presented to the International Advisory Committee when we needed to seek the approval for the signing of the Memorandum of Understanding between the Royal College of Psychiatry London and Health and Medical Education Department of Jammu and Kashmir. I hope you are able to see the screen. The photograph on the screen is of a famous river that passes through Srinagar and then goes to Pakistan, called River Jhelum. You can see on the side of the river there are boats in which people basically live. I'm going to briefly describe, if you can see on the slide, the background of the psychiatric disease hospital in Srinagar, Kashmir. It is a 150-bedded hospital and is the only hospital for mental health in the whole of the valley. It is the main referral institution for all the patients suffering from any mental illness. It provides to and fro referral services with other associated hospitals or Government Medical College Srinagar. The hospital provides teaching program for both postgraduate and undergraduate students of the Government Medical College Srinagar and also provides a rotatory training program to the medical interns who are affiliated with it. Now I'm going to explain the district mental health program, which basically is the flagship of mental health intervention in the community. It was launched in 1996 and 97, and it was plan was to cover 123 districts in the ninth year plan. Its primary aim was that it was going to envisage a decentralized community-based approach to the problem, including training of the mental health team at the identified nodal institutes within the state, increasing awareness about mental health problems and effective health seeking patterns, Adequate provision of services for early detection and treatment of mental illness in the community itself, with both outdoor, and indoor treatment and appropriate referral measures, collecting data and experience for future planning, research, and improving service provision. These are some of the dates about the launching of the district mental health program in India. This slide shows the various reports about the World Health by the World Health Organization. If you see, it's a World Health report. It focuses on mental health, World Health Survey, then District Mental Health Program 123, District 2007-2008. The important event is 2012 when WHO Executive Board adopts a resolution proposed by India, US, Switzerland to deal with the mental health problems and social sector. This is the photograph of the famous Dal Lake. These photographs are taken by my colleague Dr. Basharat, who is a consultant medicine in states. Although the district mental health program was launched, there were certain limitations to the services that it could provide. That treatment get in universal access to mental health services. Gaps are even larger with regards to preventive, promotive mental health problems as well as rehabilitation services. We are too slow in realizing the basic human rights of the people with mental illness. There is lack of technical support, including a range of inputs from establishing a mental health information system to human resource planning and implementing clinical management protocols. There is non-availability and amendment of guidelines without consultation or guidance. Regular consultation and learning from the first also did not take place. There is absence of uniform guidelines and technical support, and the objectives of the programs were interpreted differently in different states. For example, the integration into the primary healthcare and the desirability of the special facilities at the satellite outpatient clinics were interpreted by the district mental health program districts in different ways. And in most places, it was just reduced to specialist-enabled outreach clinics rather than the primary care-based delivery of the mental health services supported by the specialist. There was clearly a lack of clarity about the goals of the district mental health program, and one of the reviews found that 85% of the health personnel stated that spreading awareness was the main purpose, following by integration of mental health and genital health services was the second most important purpose. Psychiatrists and clinical psychologists stated that the main purpose of district mental program was capacity building of the health system for mental health service delivery. I think this is a quite important slide. There's basically a poor coordination at the ministerial level. You see the responsibility of rehabilitation is the responsibility of Ministry of Social Justice and Empowerment, while mental health is the responsibility of Minister of Health. Many people with mental illness, especially those with chronic mental illness, require a combination of medical treatment and rehabilitation to facilitate recovery. The lack of seamless service provision of health and rehabilitation services can be partly attributed to this separation of responsibility towards health and rehabilitation and the lack of intersectoral coordination in the delivery of these services. There is also a lack of coordination at the state level. The Department of Psychiatry and Medical College come under the Directorate of Medical Education, while the primary healthcare centers are under the Directorate of Health Services or Director of Public Health in most states. In many states, the lack of coordination between these two directorates impacted negatively on the implementation of district mental health program. This is one of the important components that we will be focusing on the mental health gap program so that there is better coordination between the primary and the secondary care services. Coordination difficulties at district level. There is lack of uniformity in the nodal officer for coordination of the district mental health program in some districts. So we are not too sure who the nodal officer is and what his responsibility is. Since there are two separate departments, head of department of psychiatry is the nodal officer at some places, the principal of the medical college or the secretary of the department of health and family care is at some other places. Teaching centers, they have limited public health perspective, little experience or incentive to work in the primary care settings. And they did not accept the core idea of integration of mental health with primary health care. I think this is the problem that continue to be faced in the mhGAP training program that we are conducting across the globe. There is deficit of simple treatment guidelines used by the health workers, identification and management of the mental illness. That's was the reason we specifically focused on mental health gap intervention guide formulated by WHO to overcome this deficiency. There is no technical support group to prepare and deliver such guideline. Lack of focus on the rights of the person and lack of sensitization of staff to avoid rights violation. There is poor information base, no information on attendance and clinical and functional outcome, absence of state and monitoring system, no essential and periodic reviews, no scope of innovation, no information or outcome of treatment. Basically, there is no monitoring of the effectiveness of any training program or any strategy that has been implemented, which I think we focus specifically in the mhGAP training program that we did in District Gandharbal. There is inadequate human resources, there is lack of appropriate trained human resources, rigid recruitment criteria for specialists, and lack of involvement of the non-specialist. This second component is the one which we will be specifically focusing in our mhGAP training program. There was lack of training for nodal officers, program officers, psychiatrists in the implementation of the program. So that was what was stressed on to train the trainers in the mental health gap training program to overcome this deficiency so they are clear about the role of the primary and secondary services in the implementation of mental health gap program. There are issues about the content of the training with health personnel wanting to be done in simple language, using case studies, increasing frequency, need for refresher course. That's what we will be focusing on the mental health gap. Lack of training for professionals at a primary health level like community workers, which will be focusing again in the mental health gap. Absence of training of social workers and their role. Training focused on hard skills with little emphasis of soft skills, personal development and leadership skills. So service delivery just revolved around the medical officer or the psychiatrist, negating the role of other professionals, community leaders and non-specialist force, and the role of the doctor was just limited to repeat prescription or referral to the specialist. This unit-dimensional approach on an isolated medical model focused on symptom reduction with medicine and not on recovery using a holistic biopsychosocial approach. This was one of the major issues that we are facing is the non-availability of drugs and that this prescription of drugs not based on any scientific rationale. Drugs budget become exhaustive because of the purchasing of expensive drugs. There is no availability of psychosocial treatment, and the psychology social workers were largely utilized for administrative work and little time for intervention with the clients of the program. It was also not oriented to a continuing ongoing model which includes follow-up and engaging of the patients, and there was clear failure of the process of care delivery rather than the concept of public health. Lack of continuity of care or lack of support in the community has led to extensive stay of patients in the psychiatric disease hospital when they could be discharged in the community with support in the community, and patients who are discharged have a relapse or a loss to follow up. Developmental centers, employment center, counseling center, they are non-existent at least due to lack of trained human resource for these tasks. There was no near total absence of users and caregivers in the design, implementation, or monitoring of the program, and no provision for users and caregivers to question the health system on the staff when they were not available. There was no availability of the care. Poor involvement of NGOs and private sector, absence of organized approach to engage with civil society, bid to stakeholders' participation failed with several dynamic players wanting to play a role but not being offered opportunity. There was a presence of is the presence of private sector, but no mechanism for coordination for delivery of services. There is inadequate provision of secondary or specialist services, especially for the old age and child and adolescent. They are missing and they need to be developed. Some school counseling services are being provided by the Ministry of Human Resources and Development, and older people were notable for their absence. The lack of crisis team in the community, ambulatory services, daycare, and mental health first aid, they were non-existent in the program. This is an email that I received for Professor Vikram Patel, who is the Professor of International Health Medicine, Senior Research Fellow GAVA. He is an advisor to WHO Expert Advisory Group, member of Economic Forum, Global Forum, and also member of the Mental Health Policy Group for the Government of India. I'm just going to read this paragraph that's part of the mail. It was basically sent how to evaluate the training, what we need to focus on once the training is complete, and stress the role of focusing on competencies rather than knowledge and attitude, which is a weak predictor of the impact of the outcome of the training. And will I just like to read the last paragraph, last line, that one of the major reasons for using local expert centers is to also use the training as an opportunity to develop collaborative relationship between the primary and specialist care, a key requirement for the successful integration of mental health in primary care. So these were some of the recommendations that were formulated and submitted. One was the need to evolve the collaborative arrangement with strong community participation, linking with voluntary sector and civil society initiatives with academic institutions from interdisciplinary background, and to utilize the private sector knowledge and skill-based educate safeguard against commercial interests prevailing over public interest. Now, this was the recommendation we submitted to the Royal College and how the Royal College could help. It could help with developing the curriculum of the mental health for primary care workers. Here we are using the mhGAP guide formulated by the WHO, which Royal College is using in training across the world. Curricular development in addition to mhGAP on mental health for non-specialist, specialist and non-specialist workers. Curriculum development for teachers, police, and other stakeholders. Implementation of curriculum through teaching both specialist and non-specialist workforce, which we will focusing basically in the current mhGAP training program. Focusing on development various employment projects, residential service, other outreach services. intersectoral work and liaison with primary care services. These are a few other things that we think that college might get involved, and if possible, we can seek the help of the college in contributing or effectively implementing the aims and objectives. We are grateful to the support and advice received from the Iraqi subcommittee and also support from the Special Interest Voluntary International Psychiatry Group, which recruited and was able to send volunteers for training to Kashmir, which led to the successful completion of mhGAP training in Kashmir. Now that was about the background of the problem that we are facing and which we needed to overcome when we are going to implement the mhGAP training program. Now we're going to focus specifically on the mhGAP training program that we formulated and conducted. This was a noble initiative initiated by the Royal College in collaboration with Health and Medical Education Department of Jammu and Kashmir with support by WHO Geneva. This basically is my profile on the Mental Health Innovation Network, which is run in collaboration with World Health Organization, Grand Challenges Canada, and London School of Tropical Medicine. Before explaining the program, I would like just to acknowledge the people and the various stakeholders who provided advice and support in my project. I would like to acknowledge the role of the entire mhGAP team, my teachers, my friends, my colleagues, and family members. I would also acknowledge the support of faculty and staff of Imam Hussain Al Islam Hospital in Kashmir, who supported us in conducting a few pilot training project programs before the launch of the mhGAP project in Kashmir. This is a photograph of the Imam Hussain Hospital based in Srinagar, Kashmir. I would like to offer my thanks to Professor Rachel Jenkins, she is the Emeritus Professor of International Psychiatry and was the research collaborator on behalf of World Health Organization. It was Professor Jenkins who inspired me to take this project. I met Professor Jenkins in one of the congresses of the Royal College of Psychiatry where she was giving a presentation on the work that the Royal College has been doing in Iraq. I would like to offer my thanks to Royal College of Psychiatry and to Professor James U. Bailey, the immediate past president of the Royal College of Psychiatry and current chair, Academy of Royal College, United Kingdom. Professor James U. Bailey was responsible for approving the proposal of the mhGAP project on behalf of the Royal College of Psychiatry. This is the president. This is our president, Professor James U. Bailey. This is at the Congress in Birmingham this year. I would like to offer my thanks and acknowledge the role of support of President of the Royal College of Psychiatry, Professor Sir Simon Wesley, for his approval and signing of the Memorandum of Understanding between the Royal College of Psychiatrists London and the Government of Jammu and Kashmir. See on the right hand is Professor Sir Simon Wesley, the President of the Royal College. This is at the Pathfinder dinner, which was one of the important places where we initiated the second component of our project of students interactive program, which I'm going to describe later. I would like to offer my thanks to Iraqi subcommittee of the Royal College of Psychiatry London, especially Dr. Muhammad Al Uzri. This is a photograph taken by outside the Royal College of Psychiatry, London, with myself and my state coordinator, Dr. Muhammad Muzaffar Khan. Dr. Uzri is one of the authors of this report that explains the launch of the new Iraq mental health from Leicester. This is basically a summary of the annual report of Royal College 2014, in which Royal College acknowledged and considered the mhGAP training program as one of the achievements of the Royal College. I would like to offer my thanks to Dr. Shekhar Saxena, WHO Director and Substance Misuse and Head of the mhGAP project in the world, who provided technical assistance to mhGAP project in Kashmir along with his team. That is basically the profile of Professor Dr. Shekhar Saxena, the Director at WHO. This is the mhGAP forum this year at the WHO headquarters in Geneva, presided by Dr. Shekhar Saxena, Director WHO. Again, a photograph from the mhGAP forum. This is a photograph with Dr. Shekhar Saxena at the WHO headquarters this year, where I attended the 7th mhGAP forum. It was at this forum that the mhGAP Kashmir was nominated by Mental Health Innovative Network as the most popular innovative project in the world. As mentioned earlier, I am thankful to Professor Vikram Patel for his advice, support, and guidance. This is Dr. Shrahush India, who is the principal investigator for Prime, who is receiving the award on behalf of Professor Vikram Patel. The award is being conferred by Dr. Salimur Rahman, Director of Health Services, and standing next to him is Dr. Peter Hughes, leading the team of Royal College to Kashmir. These are the views of the Professor Vikram Patel about the mhGAP project in Kashmir, which were presented to the mhGAP forum this year. Vikram Patel has also been named as one of the most influential people in the world by the Time magazine. I would also like to acknowledge and appreciate the excellent support of Government of Jammu and Kashmir to mhGAP project, which led it to being the best innovative project in the world at the WHO Assembly in Geneva, from more than 120 nominations by more than 100 organizations across the globe. This is the photograph showing that mhGAP Kashmir being nominated as #1 innovation out of more than 120 innovations. This is a photograph of the Mental Health Innovation Network team led by World Health Organization, Grand Challenges Canada, and the School of Tropical Medicine. This is Peter Singal, head of Grand Challenges Canada, with Dr. Shekhar Saxena at the WHO forum in Geneva this year. I would like to acknowledge the support of the Government of Jammu and Kashmir for the excellent support for monitoring and evaluation phase of the mhGAP project 2014-2015. I would like to offer my thanks to Honorable Minister of Health and Medical Education, Chaudhry Lal Singh, Commissioner Secretary Health and Medical Education, Dr. M.K. Pandari, and the current Director of Health Services, Dr. Sumir Muthu. This basically I will be showing a photograph where the Honorable Minister for Health and Medical Education, Mr. Chaudhry Lal Singh, is giving an award of appreciation to CMO Honorable Dr. Kasana for his excellent guidance, support, and supervision to mhGAP trainees of District Honorable in the successful completion of monitoring and evaluation phase of mhGAP Kashmir despite massive floods. In which Dr. Salim Rahman, who initiated the mhGAP project, invited the team from the Royal College of Psychiatry standing in the background. I would like to acknowledge the role of the previous government. I would like to acknowledge the role of Honourable Minister of Health and Medical Education, Mr. Taj Mohideen, Commissioner Secretary Health and Medical Education, Mr. Ghaznafar Hussain, Director Health Services Kashmir, Dr. Salimur Rahman. This is a photograph showing the Honourable Minister, Mr. Taj Mohideen, arriving at the inaugural function of the mhGAP training program, where Honourable Minister announced the signing of the MOU between the Royal College of Psychiatry London and the Health and Medical Education Department of Government of Kashmir. Honourable Minister announcing the signing of the MOU between the government and the Royal College of Psychiatry London. Dr. Peter Yu discussing the mhGAP MOU on behalf of the Royal College of Psychiatrists London. This is a list of the memorandum of understanding that the college has with various organizations, and if you clearly see, it mentions Institute of Mental Health and Medical Education Department of Jammu and Kashmir as one of the organizations with which they had a memorandum of understanding. Again, various organizations across the globe with which college has a memorandum of understanding or affiliation. I am highly grateful to Director Health Services Kashmir of Salim Rahman, under whose leadership this mhGAP project became possible and successful. This is the annual achievements of the Director of Health Services Kashmir. It mentions that mhGAP Kashmir as one of the achievements of the government of Jammu and Kashmir. Now I would like to acknowledge the role of the mhGAP trainers. These are the list of the trainers who came for in the first phase of mhGAP training that extended over 2 weeks. These are all mhGAP trainers. This photograph is being taken in one of the houseboats after the completion of the mhGAP training. The training included trainers from both UK. We had a local Kashmiri consultant who is a consultant in UK but was part of the team, Dr. Sajad. If you see him standing next to me on the right. This is the second team of mhGAP that came in 2014. I think Peter Hughes, Sajad were part of the previous team. Ryland and Pamela Moodley, they joined the second team. This is award of appreciation being given to the team by Dr. Salim Rahman at the completion of the training. We would like to appreciate the role of the mhGAP trainees. These are the photographs taken at the end of completion of the mhGAP training of 2013, and this is for 2014. I would like to offer my thanks to Institute of Mental Health Neurosciences in Kashmir for their support in conducting the second phase of mhGAP training. I would like to offer my thanks to J&K Police, especially Asam Sahai, Additional Director General Police, and Dr. Mohammad Muzaffar Khan, Director Police Direction Service and State Coordinator for mhGAP project in Kashmir, for providing foolproof security to the mhGAP trainers. The award of appreciation being given to Asam Sahai, to Dr. Mohammad Muzaffar Khan. I would also like to acknowledge the role of the NGOs, especially Health Foundation, the chairperson, Mr. Negar Shafi, ActionAid India, corporate sectors, Jammu and Kashmir Bank and TCI Siemens for their valuable support and contribution to the project. This is Mrs. Nigat Shafi at the inaugural function of the first mhGAP training program. Finally, I would like to thank the people of the Valley whose support and prayers made the mhGAP Kashmir a success as depicted in the photograph of the Mental Health Innovative Network. So this photograph, it shows a lattice window. This is a painting made by one of the renowned Kashmiri artists depicting a Kashmiri culture and behind which a woman is standing, raised arm, praying for the success of the project. Now, just going to having complete the acknowledgements, I will going to explain and go through the mhGAP training program and about as how we went about it, what were the problems we faced, and how we successfully managed to overcome those problems. This was initial recommendation from Professor Rachel Jenkins when I wrote to her about the program. If you see clearly, she mentioned particularly certain important things that we needed to take into consideration. Establish mental health professionals at district level who can supervise primary care staff, and organize regional mental health professionals for support and supervise district level support in her experience, which she feels were lacking. It mentioned it is these layers of support and supervision which are likely to be missing in Kashmir and which are likely to make a large difference to the long-term and sustainability of the impact of the training. If they are to give adequate support, these higher levels also need training about the mental health in primary care, which is so different from secondary care. So this is the role of training the trainers component, which we will be focusing now. That people who were trained, they will be specially trained, and other professionals and other psychiatrists will be trained to deliver training. Develop health management information system for monitoring, assessment, diagnosis, treatment, and referral. That was the second phase of the mhGAP training program that we did. This was the outcome of my first meeting with Professor Sue Bailey, president of the then past president of the Royal College of Psychiatry in London. Clearly, she mentioned about the Iraq model and the role of Dr. Peter Hughes to work out a priority plan, what we would like to achieve over the next 4 to 5 years. We also sought advice from Professor Dinesh Bugra, who is the president of the World Psychiatric Association. We had a meeting with the World Health Organization, this was the outcome of the meeting, which was endorsed by Dr. Shekhar Saxena, that WHO will be providing technical support access to training material which WHO has given permission to use. They will be providing regular advice support as projects proceed, which they did. And it was agreed that I will be serving as the coordinator between the WHO, Royal College, and the Kashmir government. We also agreed to discuss how the mhGAP program could be implemented and integrated into the district mental health program, which was stressed both by the college and the World Health Organization. This is the statement of the president of the Royal College of Psychiatry. The Royal College of Psychiatry is a committee to supporting members, providing mental health education across the world. Our volunteer scheme was set up with this core belief in mind. I'm very pleased that the college members are prepared to offer their time and expertise. I'm delighted this initiative has come to fruition, and thanks out to Dr. Akil and Dr. Peter for the hard work set in this training. I hope the participants find this experience enriching and rewarding. This basically is the mhGAP intervention guide formulated by WHO, which we used in our training. These are the various forms of teaching procedures or teaching ways which we can say we used, which includes having group discussion. This photograph is this is Professor Yusuf Masha. He was the ex head of department medicine, Government Medical College, Srinagar, and he attended the full 5 days of the mhGAP training. This mhGAP training motivated him to add another chapter of mental health to his book of trauma medicine. Dr. Peter Hughes supervising the group discussion, role play being conducted by Dr. Peter Hughes, presentation being given by uh, mhGAP trainers. Of these various training teaching methods that we used, we evaluated them and sought the feedback from the trainees. Role play was considered the number one, followed by group work, case discussion, and lectures and case presentation were considered the last. This photograph is basically evaluating the results of feedback following the completion of the training. Once we completed the training, a report was formulated and which was submitted to the college, and the college with recommendations forwarded those report to that report to the government of Jammu and Kashmir. You see, the letter, this report had a covering letter to Director Health Services, Dr. Salim Rahma, with copy to Commission Secretary Health, Mr. Ghazanfar Hussain. This chart basically depicts the number of patients that within the outpatient of the psychiatric disease hospital. You see, over the period of years, it has been on the rise due to political turmoil that has been there going on the last couple of decades. We did a survey before starting the training, and we asked all the trainees to write down the number of cases and the type of cases that they had seen over the last 1 month before starting of the training. You see, 620 cases were new, and the most common mental illness that they had seen was depression. This was the participant background in the first week of the training. Participant background in the second week of the training. Females being more in the second week rather than the first week of the training. This was the evaluation of the pre and post test results. We used the questionnaire that has been formulated by WHO, and we conducted this test before and after the training. See that before the training it was 68 and the results were increased to 84 in both the first and the second week of the training. This was the feedback regarding the training program that was delivered. We focused on clinical relevance, structure, and clarity of teaching. As you can see, all the three modules, they were quite appreciated by the trainees. Again, overall score of week 1. Feedback results of relevance, structure, and clarity in the second week of the mhGAP training. Overall score. This is a photograph of me and Dr. Muzaffar presenting the poster to the Royal College of Psychiatric Congress in London after completion of the first phase of the training. Having completed the first phase of the training, in which we trained, as you can see, more than 100 professionals of various disciplines across the whole of Kashmir. In fact, the interesting fact was that Dr. Salimur Rahman issued order so that the doctors and nurses could be deputed from all 12 districts of Kashmir. And besides the government sector, as mentioned earlier in my earlier presentation, we ensured that the NGO, the social workers, the police personnel, the teachers, and all stakeholders were involved as recommended in the initial presentation as one of the reasons that can lead to success of the mental health program in the community. We started the second phase of mhGAP training program after 1 year in 2014. We asked the trainees who attended the first session to attend the session, and we did the evaluated and sought their feedback about the experience over the last 1 year with regards to use of the mhGAP training with regards to the patient care. This is a list of attendants. Almost 65 of them reported back and came for the training. Again, this was the feedback regarding the refresher course which we conducted, in which the doctors and paramedics and other professionals who had done the training shared their experience with regards to the use of mhGAP intervention guide and how it was helpful in identifying the various patients in their day-to-day work. We repeated the pre and post training test that we did in the 2013. So in 2014, with the training ran only for 1 week, but we had two groups running in rather than rather than the groups running for 2 weeks. Again, a group feedback of 2014 mhGAP trainees, clinical relevance, structure, clarity of teaching, and overall feedback. Again, feedback of group 2. This is the feedback that has been provided by the trainers. I would like to share the feedback by Dr. Lucy Porter, who was at that time a psychiatric trainee at the Mosley. She mentioned that mhGAP training in Kashmir was a fantastic experience for me, through which I feel I have developed multiple skills, including the planning and delivery of training to a multidisciplinary audience. Our stay at the Regional Institute Health and Family Welfare was great and could not have been more welcoming. I hope there will be further mhGAP training in the future. Dr. Lucy Porter went on to conduct mhGAP training programs in Zimbabwe. This basically is her interview after completion of the mhGAP training in Zimbabwe, in which she specifically mentions about her experience in Kashmir. She mentioned that evidence-based for global mental highlights high burden of mental illness in low-income countries. Therefore, it is crucial that services for mental health are scaled up in a meaningful way. Lack of human resource is one of the major barriers, and creative solutions needs to be implemented. A compelling research that supports task system where health workers with a shorter duration of training can provide valuable care for people with common mental health disorders, enabling them to lead healthy, productive life. mhGAP training in Kashmir was an incredibly effective experience or example of this. This was another feedback that was given by one of the mhGAP trainees. This was an article that was basically got published in one of the newspapers, in which he mentioned that they learned a wonderful term named human placebo. A galaxy of doctors, psychologists from Royal College, whom I could not imagine of meeting even in a dream, taught the basics of human care to the patients having psychiatric ailments. Galaxio again, he mentioned at the end that they were quite impressed about the quality of the training that was being provided. This is the overall feedback by the trainers. He mentioned that mhGAP training was well organized, well designed, easy to teach and learn from, and very applicable. This was the paper that was published this year by Dr. Ryland and Lucy Potter, both psychiatric trainees who had come as part of mhGAP to Kashmir. If you see, they clearly mentioned that by participating in the volunteer program have helped them to experience the key issues in global health, such as cultural factors, stigmatization, availability of resources, structures of the various health system. This was the feedback by WHO from WHO headquarters Geneva after the completion of the mhGAP training. It also mentioned about the Manchester orientation workshop. That was the training the trainers workshop. That was second workshop conducted by Dr. Peter Pugh, Dr. Sophie Thompson, both of whom came to Kashmir in the first year. And the first one was conducted in March before we started the first phase of training, which was attended by more than 100 participants at that time. Following the completion of the training, our aim was to get a memorandum of understanding signed between the Kashmir government and the Royal College of Psychiatrists, London. So we're trying to seek the views, opinions of the various experts around the globe as to what should be incorporated into the terms and conditions of the memorandum of understanding. These were some of the recommendations that were some given by Dr. Shekhar Saxena, Director WHO, mentioned about training to primary care providers treating disorder, especially related to stress. WHO has a new manual for this, psychological first aid training to healthcare, social care, emergency, police, and staff. This was the covering letter that came with the MOU that the second batch of mhGAP trainers brought with them. It was brought by Dr. Peter Hughes, and in which it is signed by Professor Sir Simon Wesley, who is the current president of the Royal College of Psychiatrists, London. It's addressed to Mr. Ghazzafar Hussain, the Commissioner Secretary, Health and Medical Education, who signed the MOU on behalf of the Kashmir government. These are the main components of the Memorandum of Understanding: capacity building in primary care to deliver quality care and mental health service across the Kashmir region, enhance accessibility of mental health care to rural areas, good quality secondary care advice to primary care, Use of mhGAP intervention guide is one of the tools of capacity building, principles of psychological first aid, enhance public education of mental health, overcome stigma against mental health, advocacy and respect for the rights of patient mental health, intersector collaboration to enhance mental health well-being, develop training in mental health at primary and secondary care level, mental health training to providers of education and social care, ensure high quality supervision, monitoring, evaluation in the provision of mental health care. Having completed the second phase of training, in which we basically specifically focused on one district of district Ganderbal, all most of the doctors we focused on district Ganderbal so that it was easy to monitor and evaluate the outcome rather than focusing on doctors from the entire valley. Well, due to start the monitoring evaluation project, and unfortunately there was a massive flood which start happened just 1 week after the completion of the second phase of training. I'm going to share with you some of the photographs to show the extent of damage the floods caused in Kashmir. This is the center of the city of districts of Srinagar, the capital of Kashmir. This was the aerial view of the flood in Kashmir. This is again the recommendations of Professor Vikram Patel regarding the monitoring evaluation, which we stressed upon the focus on the competencies rather than on attitude. So that was the reason, that was what we were focusing on. And to monitor the competency, it's quite important to conduct the supervision, which was one of the important component of our second phase of training, as well as monitoring and evaluation. Unfortunately, this monitoring evaluation phase got delayed by 6 months, and following that, we had to conduct several refresher courses to refresh the memory of the doctors who had undergone training before the floods. We managed to get the ball rolling, and these are the list of the uh, healthcare centers that participate in the monitoring and evaluation phase of the mhGAP Kashmir. This is one of the registers that got we printed and that was used for recording the data in the primary healthcare centers. This is the summary of the number of cases you see in May. In the 3 months that we use as the pilot project, this is the number of cases. These are the number of cases seen in the month of May. This is in the month of June. And month of July. So total number of psychiatric cases seen in the 3 months. You see depression topped the list. This was evaluation of about treatment and use of psychological therapy and referral. In fact, non-prescribing professionals, they used to provide counseling and then refer them to the specialist. But the specialists who used to psychiatrists who used to come to Ganderbal twice or thrice a week to see these patients, or the complex cases ended up being referred to the tertiary care center. Number of cases identified by prescribing and non-prescribing doctor. You see, interestingly, non-prescribing doctors have identified more cases than prescribing doctors. Now, second important component that we needed to focus on was the supervision, which was a local supervision provided locally and the distant online supervision. I'm going to just focus on the distant online supervision. We're grateful to King Corey London who allowed us to use this software devised by them called Medicine Africa. It's an online platform that connects doctors, health workers, and other professionals. It was built for the Kashmir King's That Somalia project and support other partnerships between UK and Palestine, Kashmir, and Uganda. It can be used for educational training to improve clinical reasoning, teaching faculty to conduct better examination or learn research methods, strengthening or developing clinical services, giving tailored advice, planning or collaborating on health service research or data collection. See, these are some of the projects, some on Medicine Africa. See, we have got two projects: Kashmir UK Global mhGAP Supervision Partnership, and the second was Kashmir UK e-learning interactive super partnership, in which the medical students of UK and the medical students of Kashmir interacted online and discussed various modules of mhGAP intervention guide. Now, this is the list of the trainees and trainers who provided them online supervision. I'm thankful that all the trainers who had come for mhGAP training were available and contributed to providing online supervision for mhGAP trainees. I would like to acknowledge the work done by Said Owais, who was a research fellow employed for mhGAP Kashmir. Having completed the project, we analyzed and evaluated the results and submitted it to both Royal College and World Health Organization. The results were presented by me to the mhGAP Forum. I'm just going to summarize give a brief background about what the mhGAP Forum is. The vision of the mhGAP Forum is to provide effective and humane care for all patients with mental, neurological, and substance use disorders, particularly focus on the vulnerable ones in low and middle income countries by improving service delivery, reducing the treatment gap, and increasing the financial and human resources for mental health care. This is the mhGAP forum this year. I was representing my institute. I'm going to basically summarize the mental health action plan that was devised in 2012, and the aim is to 2012 to 2020 to implement various proposals that were drafted in the fourth mhGAP forum. It specifically focused on comorbidity with physical problems and coexistence of mental disorders, the linkage of mental health with HIV, AIDS, and NCD, reference to discrimination and disabled people, the linkage with social determinants of health, nutrition, and environmental aspects, inclusion of spirituality as a dimension. That's interesting. The quality aspect of health and social services, the concept of culture, acceptability, and inclusion. Discussion of suicide not to emphasize only the young in terms of vulnerable population, intervention of suicide prevention for young people, research component, and to add more information on the models being implemented on scaling integrating mental health into primary health care, support of health care, support of care to caregivers and families, issues the important parallel of NGOs, mental health issues of women and girls, mental issues in children, and the role of e-medicine, e-mental health tools in implementation. The very issues that were raised that there are weak links to WHO stated priorities, international partners were associated with all activities, TIC was not strongly enough reflected, more positive rebranding of mental health needed. It should reflect mandate for a greater integration and should include the importance of spirituality for well-being. To clarify as to whether all the implementation options were optional or were some were priority action, to make the action plan discourse more global than a Western public health model and more emphasis on transcultural issues and potential values of other cultural models. I basically submitted a paper to the British Journal of Psychiatry in which we mentioned that how mental Western media can learn from mhGAP and mhGAP can learn from Western models. So it's a give and take approach rather than just blindly accepting or endorsing the Western model, which we then find it difficult to integrate, implement in our culture. India was part of the member states when in 2012, and they had the privilege of sponsoring along with Switzerland and US the resolution of mental health executive board of WHO in 2012, which led to the development of global mental health action plan. This issue, see, it clearly acknowledges the evolving threat of mental disorders and action needed as soon as possible. I think depression was the theme for the World Mental Health Day in 2012. It mentioned about the need to revise the district mental health program and with substantial financial allocation. And India welcomed the technical assistance which WHO continues to provide across the globe. These are the various international and national partners who are involved in implementation of mental health action plan. See, it is Institute of Mental Neuroscience in Kashmir, India, is one of the international partners in the implementation of the mental health action plan. Finally, I like to share this slide. This is a photograph from inside of a Concorde plane. That's the only plane which has got no class distinction with regards to service provision, which I think needs to be the fundamental principle of our project. I would like to thank everyone for participating in this webinar. So if you have any question, uh, feel free to ask. You can write, or if you can want to speak,